Hello and welcome to your ultimate guide for the ATI Pharmacology. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your ATI Pharmacology exam with total confidence. In this video we'll cover pharmacokinetics, therapeutic range, medication routes, medication safety, dosage calculations. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your ATI Pharmacology exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Let us begin with pharmacokinetics, which is simply what the body does to a drug. Picture a medication as a traveler moving through your body on a 4-stop journey. From the moment a tablet is swallowed until the drug leaves the body, 4 processes unfold in sequence. We remember them with the word ADME, standing for absorption, distribution, metabolism, and excretion. The first stop is absorption, the movement of a drug from where it was given into the bloodstream. 3 principles apply every time. The rate of absorption determines how quickly the medication takes effect. The amount absorbed determines how strong that effect will be, and the route you choose affects both the rate and the amount. Let me make this concrete. When a drug goes straight into a vein, absorption is immediate and complete because there is no barrier to cross. When a client swallows a tablet, absorption is slower and variable because stomach acid, food, and gastric emptying all interfere. A medication placed under the tongue absorbs quickly and bypasses the liver entirely. The second stop is distribution, the transport of the drug from the blood out to the target tissues. Blood flow matters enormously here. Conditions like heart failure, shock, or peripheral vascular disease slow distribution. The drug must also cross cell membranes, and only fat-soluble medications can pass the blood-brain barrier or cross the placenta during pregnancy. Now, here is a detail examiners love. Many drugs travel while attached to plasma proteins, mainly albumin. Only the free, unbound portion of the drug is active, while the bound portion sits idle. When a client has low albumin from malnutrition, liver disease, or burns, more free drug circulates, raising the risk of toxicity at a normal dose. The third stop is metabolism, also called biotransformation. This is where the body chemically changes a drug, usually into a less active form. The liver is the powerhouse of metabolism, though the kidneys, lungs, and intestines help too. Here is a key idea called the first pass effect. A swallowed drug travels through the liver first, where much is inactivated immediately. Several factors change how fast metabolism happens. Infants have immature liver enzymes, and older adults metabolize more slowly, so both groups often need smaller doses. Liver disease slows metabolism, allowing drugs to build up. Poor nutrition removes the cofactors enzymes need. And when 2 drugs share the same enzyme pathway, they compete, pushing levels toward toxicity. The fourth and final stop is excretion, where the drug leaves the body. The kidneys are the main exit door, which is why we watch lab values like blood urea nitrogen and creatinine before and during therapy. When the kidneys are not working well, drugs linger and effects intensify. Drugs also leave through bile, exhaled air, sweat, and breast milk. So, how does this appear on your exam? Expect questions asking which organ handles metabolism, or why a client with kidney damage needs a lower dose. To keep the 4 stops in order, just remember the word ADME. Think of a drug checking into a hotel, moving through its rooms, then checking out. That image sticks under pressure. What we just covered is exactly the type of material you will find in our free practice question bank. These are not just basic recall questions either. They are designed to test your deep understanding of how drugs move through the body, just like the real nursing exam will. Go try a few right after this video. Right. Now let us explore the therapeutic range, one of the most important dosing ideas. Every medication has a sweet spot. We want the blood level to stay above the minimum effective concentration, where it actually works, but below the toxic level, where it causes harm. Staying between those points keeps the client both safe and helped. Closely related is the therapeutic index, which describes the safety margin of a drug. A wide index means a large gap between helpful and harmful, so routine monitoring is not needed as with penicillin. A narrow index means a tiny margin where small changes become dangerous. Digoxin, lithium, warfarin, and theophylline fall here, so we check levels frequently. This brings us to peak and trough levels, which students often confuse. The peak is the highest concentration in the blood, occurring after the dose depending on the route. The trough is the lowest concentration, and you draw that blood sample immediately before giving the next dose. Remember it this way. Trough comes right before and peak comes after. Half-life is the time it takes for the drug level in the blood to fall by half. A short half-life means the drug leaves quickly, so we dose it often. A long half-life means it lingers, so we dose less frequently, though it builds up more easily. A stable, steady level is reached after about 4 half-lives. Now let us flip our perspective. While pharmacokinetics is what the body does to the drug, pharmacodynamics is what the drug does to the body. Drugs act at binding sites called receptors. An agonist binds to a receptor and switches it on, mimicking the body's own chemicals. Morphine activates opioid receptors to produce pain relief, sedation, and constipation. The opposite of an agonist is an antagonist, which binds to a receptor but blocks it, preventing activation. Losartan blocks angiotensin receptors to relax blood vessels and lower blood pressure. There is also a clever in-between called a partial agonist. Nalbuphine blocks one type of opioid receptor while activating another, giving pain relief with less breathing depression. On your exam, watch for trough questions because they are everywhere. If a question asks when to draw a level to check the lowest amount, the answer is right before the next dose. Also remember that narrow therapeutic index drugs need careful monitoring. A simple trick is that narrow means nervous, so you watch those drugs closely. I know we are covering a lot of detailed information, and you might wonder how to practice applying it. That is precisely why I put together those free practice questions I mentioned earlier. They will help you work through scenarios that combine peak and trough timing, half-life reasoning, and receptor concepts, so the ideas truly stick. Let us move into routes of administration, which means the path a medication takes into the body. Routes fall into 2 big families. Enteral routes use the digestive tract, like swallowing a pill or using a feeding tube. Parenteral routes use injection, like a shot in the arm. Each route has its own rules that protect your clients. The oral route is the most common, the safest, and the least expensive, but it comes with cautions. Never give oral medications to a client who is vomiting, cannot swallow, or has a reduced level of consciousness. Always position the client upright to help them swallow safely. And here is a classic exam point. Never crush enteric coated tablets. Several routes work through skin and membranes. Sublingual medications dissolve under the tongue and enter the blood directly, so the client should not eat or drink until they dissolve. Topical creams are applied with a glove or applicator, never a bare hand. Transdermal patches release medication slowly, so apply them to a clean, hairless area and rotate sites. Eye drops require gentle, precise technique. Have the client tilt the head back and look up at the ceiling. Rest your hand on their forehead for stability, then drop the medication into the small pocket of the lower lid, called the conjunctival sac, never directly onto the eye. Afterward, press gently on the inner corner for half a minute. Eardrops have a memorable age rule that examiners adore. For adults and children 3 years and older, gently pull the ear up and back to straighten the canal. For children younger than 3, pull the ear down and back instead. Then have the client stay lying on their side for a few minutes. A few more routes round out the picture. For rectal suppositories, place the client on the left side and insert past the internal sphincter. For vaginal medications, position the client on her back with knees bent. For nasal sprays, keep the client supine, point the nozzle away from the center wall, and avoid blowing the nose afterward. Inhalers deserve special attention because clients use them at home. With a metered dose inhaler, the client shakes it, breathes out, then presses and slowly breathes in, holding that breath for 10 full seconds. A spacer makes this easier and delivers more medication to the lungs. After any steroid inhaler, the client must rinse the mouth. Feeding tubes have their own safety rules. Always use liquid forms of medication when possible, and never crush extended release or enteric-coated drugs. Give each medication separately rather than mixing them. Most importantly, flush the tube with water before, between and after the medications to prevent clogging. And always verify that the tube is placed correctly first. Now to injections, where site selection truly matters. For intradermal tests like tuberculin screening, insert at a very shallow angle, almost flat against the skin, and never massage afterward. For subcutaneous shots like insulin and heparin, pinch the fat and inject at a 45 to 90 degree angle. For muscle, the ventrogluteal site beats the older dorsogluteal. The intravenous route delivers medication directly into the bloodstream for an immediate effect. Larger needles are used for trauma and surgery, while smaller ones suit children and older adults. The big advantage is rapid onset and precise control. The big danger is that a wrong dose causes harm instantly with no way to undo it. For your exam, the eardrop rule is a guaranteed favorite, so lock it in now. Up and back for the older crowd, down and back for the little ones under 3. Also remember that the ventrogluteal site is the safe choice for muscle injections, and the dorsogluteal is out. Picture the sciatic nerve hiding nearby. If some of these route details feel like a lot to memorize, do not worry. That is completely normal, and it is exactly why I created that comprehensive practice question bank. Working through those questions will help these site selections and techniques move from short-term memory into lasting knowledge you can rely on. Now we arrive at the rights of safe medication administration, the heart of protecting your clients. ATI lists 10 rights to verify every time. They are the right client, medication, dose, time, route, documentation, education, refusal, assessment, and evaluation. These rights are not just a checklist. They are a habit of thinking that prevents harm to real people. Let us start with the right client, because giving a drug to the wrong person is a serious error. The Joint Commission requires 2 separate identifiers before every administration. Acceptable identifiers include the client's name, birth date, or assigned identification number, but never the room number. Always check the identification band, ask about allergies, and scan the barcode. Next, come the right medication and the right dose. To confirm the correct drug, read the label 3 separate times: before, during, and right before giving it. For the dose, always check that it falls within the usual safe range. And here is a non-negotiable rule. For high alert medications like insulin and heparin, a second nurse verifies the dose. The right time keeps drug levels steady and effective. Time-critical medications such as certain antibiotics must be given within 30 minutes before or after the scheduled time. Non-time critical medications allow more flexibility, often within 1 or 2 hours based on their dosing frequency. Giving medications on schedule maintains the therapeutic level we discussed earlier. The right route means using the exact path the provider ordered and selecting the matching preparation, since an ear drug is not an eye drug. The right documentation means recording the medication only after you give it, never before. If you chart it early and get interrupted, the record becomes dangerously inaccurate. Document the dose, route, time, and response. 4 more rights complete the set. The right to education means teaching clients what the drug is for and what to report. The right to refuse means respecting a client's choice, explaining the consequences, and notifying the provider. The right assessment means gathering data first, like checking a pulse before digoxin. The right evaluation means confirming the medication worked. On your exam, the right to refuse appears constantly, and the answer is almost always to respect the client's wishes while documenting and informing the provider. Remember that you assess before and evaluate after. A helpful trick is to picture yourself pausing at the bedside and running through each right like a pilot's pre-flight checklist. Remember that mastering these rights takes repetition and application, not just reading. The free practice questions are designed specifically to help you turn what you're learning here into exam-ready skills. Each scenario walks you through a realistic bedside situation, so you build the confidence to choose the safest action quickly and correctly when it counts. Let us talk about preventing medication errors, because this is where nursing vigilance saves lives. Common errors include giving the wrong drug, the wrong dose, or using the wrong route or timing. Errors also include missed doses, extra doses, and giving a medication a client is allergic to. The goal is building habits that catch mistakes early. Prevention begins with knowledge and good resources. Before giving any drug you do not know well, consult a reliable source, such as a pharmacist, a current drug handbook, or poison control. Here is an exam favorite. Pharmaceutical sales representatives are never an appropriate resource. Always gather the client's history, including allergies and any liver, kidney, or heart conditions. A safety organization called the Institute for Safe Medication Practices gives us powerful tools. They maintain a list of error-prone abbreviations to avoid, and a list of look-alike, sound-alike drug names that are easily confused. To prevent mix-ups, certain letters are written in capitals, a method called tall man lettering, so similar names stand apart clearly. When actually preparing medications, your habits matter enormously. Avoid distractions like ringing phones, because interruptions are a leading cause of errors. Prepare medications for only one client at a time, and never give a medication that someone else prepared, because you cannot verify what is truly in that cup or syringe. Your name is on it. Certain medications carry a heightened risk of serious harm if given in error, and these are called high alert medications. The list includes insulin, heparin, opioids, concentrated potassium, and chemotherapy drugs. Because the consequences are severe, these require safeguards like limited access, warning labels, and independent double checks by a second nurse. Slow down whenever you handle one. After administration, your job is not finished. Evaluate the client's response and watch for adverse effects. If an error does occur, act immediately to protect the client. Then complete an incident report, usually within 24 hours. Here is a crucial detail examiner's test. The incident report is a separate document, so you never mention it in the medical record. For your exam, remember that errors point to broken systems, not just bad individuals, so we report them openly to fix the underlying causes. When a question asks about an unsafe or unclear order, The safe answer is always to question the provider and refuse to give it until clarified. Picture yourself as the final safety gate. As we move toward the end of this overview, remember that understanding these safety concepts is just the first step. The real mastery comes from applying them again and again, which is where those free practice questions become invaluable. They are completely free. They cover every topic in this video, and they target your nursing exam success. Our final major topic is dosage calculation, which makes many students nervous, but you can absolutely master it. There are 3 equally correct methods to choose from. The first is ratio and proportion. The second is the desired over-have formula. The third is dimensional analysis. Pick the one that makes the most sense to you and use it consistently. Before calculating, you must know your standard conversions by heart. 1 gram equals 1,000 milligrams and 1 milligram equals 1,000 micrograms. 1 kilogram equals 2.2 pounds, which appears constantly in pediatric problems. 1 teaspoon equals 5 milliliters and 1 tablespoon equals 15 milliliters. Knowing these cold means you can set up any problem without hesitation. Let me walk you through the desired over-have method, which many find easiest. You place what the provider desires on top and what you actually have on the bottom. Then multiply by the quantity. Imagine the order calls for 200 milligrams and each capsule contains 100. 200 divided by 100 gives 2 capsules. Weight-based dosing is especially common in pediatrics, so let us practice the thinking. First, convert the child's weight from pounds to kilograms by dividing by 2.2. Next, multiply the kilograms by the prescribed amount per kilogram to find the total daily dose. Finally, divide that total by the number of doses per day and check for reasonableness. Intravenous calculations come in 2 flavors. For an electronic pump, you find the rate in milliliters per hour by dividing the total volume by the total hours. For a manual drip, you also factor in the drop factor of the tubing to find drops per minute. Take your time, write down each step, and never rush these. 2 formatting rules can save a life on your exam and in practice. Always use a leading 0 for any amount less than 1, so you write 0.5. Never a lonely decimal point, but never use a trailing 0, so you write 5, never 5.0. That extra 0 has caused deadly tenfold overdoses. On your exam, the most important habit is the reasonableness check. After every calculation, pause and ask whether your answer makes sense in the real world. If a problem tells you to give 20 tablets at once, something is wrong. To remember the 0 rules, think always lead, never trail. A leading 0 protects, a trailing 0 deceives. Let us bring everything together. We began with pharmacokinetics, the 4-stop journey of absorption, distribution, metabolism, and excretion, captured by the word ADME. We then explored the therapeutic range, learning to keep drug levels between too little and too much, and we mastered peak, trough, half-life, and the receptor actions of agonists and antagonists. These ideas explain dosing. From there, we traveled through the routes of administration, each with its own safety technique, from eye drops to inhalers to injections. We embraced the 10 rights of safe administration as a bedside habit, studied how to prevent and report medication errors, and finished by conquering dosage calculation. Notice how every topic connects, all serving one purpose: client safety. Here is what I want you to take away most of all. Pharmacology is not about memorizing endless random facts. It is about understanding one story of how a drug enters, travels, acts, and leaves, and how the nurse keeps it safe. When you think in terms of that story, even unfamiliar questions become approachable. And do not forget to grab those free practice questions from the link in the description below. With the depth of knowledge you gained today, combined with steady practice from those questions, you will walk into your exam genuinely prepared. They cover every concept we discussed, and working through them turns understanding into confident recall. You have just built a strong foundation that will support every other pharmacology topic you study. Be proud of the work you put in today. Review this video whenever you need a refresher. Practice those questions consistently and trust your preparation. You are more ready than you feel. Now go show that exam what you're capable of. You have got this.